Thank you very much. Good morning, everybody. I'd like to start by thanking the organisers for this fantastic opportunity to join you all this weekend and present. Since my original interaction at the Cost Aniridia, I've not had a great deal of involvement in Aniridia, but for me this weekend's been extremely insightful and educational, and I feel very humbled to be part of this session which contains such amazing research. So I'm an honorary associate professor at the University of Nottingham. My disclosure is that I'm also the founder and CSO of NuVision, and the reason why we founded NuVision was to actually create a vehicle to take clinical products that we were developing at the University of Nottingham to the patient. Without that, you can't get products into the clinic. My background is tissue engineering, but essentially I'm an amniotic membrane scientist, and that's what I'm going to be talking about to you all today. I'm going to introduce the use of amnion in ophthalmology and then go into how advances within the application of amnion have enabled surgery-free application, and then we're going to go into how this is transforming ocular surface disease management. And then I'll expand into some clinical data examples that could be applicable to aniridia. So ocular surface disease is characterized by destabilization of the ocular surface. And this can be caused by a number of factors, including infection, physical injury damaging the epithelium, chemical and thermal burns, and then obviously disease, which disrupts the homeostasis of the eye. And this includes Stevens-Johnson syndrome, dry eye disease, and of course aniridia, as we've learned over the course of the last few days in AAK. All of these causing factors can be simplified, how I simplify it, in a triangle of epithelial damage, which results in delayed healing, inflammation, I'm not sure whether you can see my cursor, yeah you can, inflammation, and then fibrosis. And this is a bidirectional triangle, so if you take out one of those, the other two can compensate, and then you end up in a cycle that you can't control. For those of you that are non-scientists, so amniotic membrane is the innermost layer of the sac that protects the baby and nurtures the baby during pregnancy. And this has a really potent function in helping the baby develop. It's non-homogenic, so it isn't rejected, and it has some fantastic qualities. We collect this, and there are other companies that do collect amniotic membrane, but we collect it through consented elective cesarean, and then once we've got the tissue, we have to go through a very stringent and heavily regulated process to preserve the tissue and then test the donors in the tissue to make sure it's safe. If you look in literature, amnion is being cited to be wonderful for many different reasons. But the three areas, or four areas, that we focus on as a research team, reflecting upon that triangle, is that its ability to actually reduce inflammation. And this function is quite potent. It has a very strong ability to help heal the eye, so epithelial healing. And then these two combined actually help prevent fibrosis and scarring, as we've been learning about this weekend. And when all these things happen together, it actually helps pain management at the ocular surface. So rather than tackling one of those elements in the triangle, amnion has the potential to tackle all three at the same time. Amnion's been used in ophthalmology for over 80 years, and if you look in literature, there's over 35,000 publications, not just in ophthalmology, but all clinical specialities. And when I actually first did this slide, I calculated that there'd be over 2 million transplants in the last 10 years. And the use of amnion is proliferated across multiple clinical specialities now, and there's almost 1 million transplants a year. When you look at the way that amnion is processed and preserved, it can be categorized into two, but three sub-areas. So amnion can either be preserved frozen, which is referred to as cryopreserved or fresh frozen, or it can be dried, traditionally using freeze drying or heat drying. The core backbone of these technologies are over 20 years old, and they were developed when scientists didn't really understand what happened to the amnion when they were preserved. And over a period of 18 years, we've researched the whole methodology of processing amnion. And we've actually been able to understand what happens. And any process that preserves amnion causes some damage to the tissue. The key thing is trying to limit that damage. And most of the products out there, particularly cryopreserved amnion, inflicts quite severe damage to the tissue that when you come to use it clinically, you're actually losing some of the benefits that amnion can offer. Logistics and getting access to this is a very challenging problem, particularly for frozen amnion, as you may know from an ophthalmology perspective in Sweden. From a clinical perspective then, although it does work, amnion is subject to surgical use because you've got to attach it to the ocular surface in some way, either sutures or glue. This makes it very difficult to use, and historically you had to be trained how to surgically use amnion, and normally it comes as part of your training program through ophthalmology. It's limited to severe and end use, as Prof. Utheim mentioned on Friday. Amnion is very good, but as a last resort, and this is because of the cost-benefit argument of putting this in the eye in an earlier situation. It is traditional amnion is costly, and because of all these limitations, until recently, there's been no routine non-surgical outpatient availability for amnion. So amnion is always what the scientists say, the big gun, when it's really needed. And if you look in literature, amnion can be associated with variable clinical outcomes, and that's in part due to the clinical procedure, but also the way that amnion is preserved as well. So over a period of nearly 18, 20 years, we looked at all the different aspects of amnion preservation, right from collection through to the way that you clean the amnion and then the way that you preserve it. And we developed a process which at the time never intended to be a clinical product. And we developed a new way to dehydrate the amnion without actually losing the things that you want to keep in the tissue. And what we were able to do was package this with under a name called the Tereo process, which we then licensed to NuVision, which now sell this in ophthalmology as Omnigen. And what this process does is doesn't add anything to the amnion. It just simply preserves the natural properties of the tissue, and therefore you can carry that forward into a clinical setting, therefore overcoming a lot of the limitations that amnion has historically faced. And by doing that, you're actually enhancing its tissue regeneration function. But from a logistics point of view, because this is dry, it can be stored at room temperature and shipped very easily. There's actually product over there you can see, and you wouldn't be able to do that with traditional amnion products. And this makes it very easy to use and apply. You can apply it to the ocular surface dry. And because of that, you can start to consider new ways of applying amnion to the ocular surface without the need for surgery, which we've done. So now I'll go on to how we've developed this and how others have developed it. Unfortunately, it's going to involve contact lenses again, so I do apologise. The way that we use amnion in a non-surgical setting is using it as a patch, as a biological dressing. So these are my simplistic diagrams of the ocular surface. If you have a damaged epithelium and inflammation, you place the amnion on the surface, epithelial side down. It protects the wound. It delivers the things it needs to help the regeneration and healing. And then the amnion either falls away or is removed over time. The actual mode of application, as in as a patch, is not new, but it's probably the most underused clinically in ophthalmology because of the justification of taking patients to theatre to apply a patch on a superficial defect. It's just never been done in its full potential. However, I think this is probably the most effective way that amnion can be used. It delivers a very potent anti-inflammatory and healing effect, and you can actually stop the progression of pathology before it even gets going. There are other attempts at making amnions that you can apply in a non-surgical setting. So some of you clinicians may be familiar with Procura, and there's a German product called AmnioClip, and this is frozen amnion pre-attached to a plastic ring, and this is probably the only way you can access frozen amnion in a non-surgical setting. There are other dry amnion products, mainly in the US, that educate the use of these under a standard bandage contact lens, but unfortunately standard bandage contact lenses don't hold amnion, so you actually lose this quite quickly, and you lose the function of the amnion. So we knew all of this before we started developing our method, and we partnered with Menicon, to adapt one of their existing bandage contact lens designs. And we've changed the geometries of the lens that we can simply apply the amnion into the lens temporarily in the clinic as part of your patient preparation. And then you can then apply that to the ocular surface, and then the lens holds the amnion in place. And it becomes a very simple procedure. You can eliminate the need for some surgery, and then you can start to consider non-surgical specialists for the application, and this is something that's happening in the UK. The uses of this non-surgical application comes back to my triangle as before. So if your condition has at least one of those, then potentially the patient is suitable for non-surgical AMT. And this is a very simplistic chart of all of the conditions that we know now that are being treated with sutureless amniotic membrane. And although the surgical use of amnion is still there in the UK, and it is growing because of the innovations that are coming, over 80% of your amnion use now in the UK is in an outpatient setting. So it's really sort of finding its position. The dark dots are where we've actually got published data. And then based on AAK, I've highlighted areas within this field that could be usable in the context of aniridia. So what I've done is just to try and summarize some of the indications that might be analogous to aniridia. So from a refractory non-healing defect perspective, QVH, Queen Victoria Hospital in the UK, has published 2 studies in quite severe, because they're a tertiary referral centre, refractory non-healing epithelial defects. And what I've done is I've summarised their retrospective study and their prospective study, which was published actually last week. And as you can see, over those 2 studies, they treated 139 what we call PED, persistent epithelial defects. But you can see the etiologies of these, this cohort is quite complex. And 61 of these were limbal stem cell deficient. And if you actually look, 13, so 10% of them were actually aniridia patients that had developed limbal stem cell deficiency, which has been a common theme across the last 2 days. Then you have other causes of PED following corneal grafts, active infection, which I'll come back to in a minute, and then also neurotrophic cornea. What they did was they treated the patients in an outpatient setting, and it was an average of 1.1 applications. So essentially, one application was what they needed to be able to get the outcome that they got. And what they were able to show over the 2 studies was that 90% of the patients treated, bearing in mind these were really highly refractory, either completely healed, which was 63%, or partially healed, which was another quarter of the patients, which that quarter went on to other procedures. So the outcomes, considering the initial presentation, is quite positive. When you break it down to the subcategories, you can see that neurotrophic cornea, 82% of those completely healed, and the keratoplasty was on par with the whole study, and microbial keratitis, and this was actually treating patients that had active infections that were managed aggressively initially with antibiotics, and then they went in with this treatment, and they actually managed to get almost 70% of these patients to a complete resolution. The group that didn't respond quite as well, which you'd expect, was the limbal stem cell deficient group. Around half of them completely healed. But when you pull out the aniridia subgroup, it's slightly higher in that group at 62%. So aniridia patients actually respond quite well to the treatment. In a parallel study using exactly the same protocol, but intervening much earlier in the care pathway, Bristol Eye Hospital treated 17 patients with very complex, again, they're a tertiary referral centre, very complex PEDs. And their average defect size, because they used some software that we were able to get hold for them, was 15 millimetres squared. Neurotrophic cornea was one of the most common causes of the PEDs, and they intervened early. So essentially, as soon as this patient was defined as a PED and that it had been predicted to be refractory, they went in with sutureless amniotic membrane, and they got a 94% complete success rate. And it could have been 100, but reflecting the complexity of this, one of the patients actually sadly passed away due to their comorbidities. So That kind of reflects the severity of the cohort. Again, their average applications was 1.2, so essentially 1. And they were able to monitor the healing rate. And what they were able to report in their paper was that their healing rate was better than the newer insulin and the traditional serum eye drop treatment strategies. And what they concluded was that early application is a key factor in the clinical outcome. So this is something that we're working on with ophthalmologists that use this. This is a new area for us, so the use of amniotic membrane in dry eye disease. And thankfully, one of the multi-choice questions that Prof at the team asked on Friday was amnion useful? Was yes, otherwise I'd be going home now and it would save me the last part of this presentation. But we do agree with this, and I'll show you why in a second. So amnion is cited as a step 4 treatment option for dry eye disease, and this is because it's a surgical option, and therefore it's always the later stage. To investigate this and the use of sutureless amnion, we partnered with Aston University, who designed a randomized controlled trial to treat patients with moderate to severe dry eye disease. So this is the extreme end. And again, it was refractory dry eye, so these patients had been through the mill with various different treatments, cyclosporine, IPL, and were no longer responding. What we did is we've developed an amnion with a pinhole to allow vision, and we were able to treat the patients bilaterally. So they had a 1 week bilateral treatment of Omnigen under a lens, and then they were followed up for 6 months. No further treatments from amnion, and they continued using their lubricants. I'm going to come to the results in a minute, but the 1 month data has actually now been published, and the full RCT has been submitted for review. Just to give you an overview of some of the key elements, we were able to reduce dry eye symptomatology, disease severity, by 65%. So essentially you're downgrading severe dry eye, which is 57 on the OSDI, down to 20 for a minimum of 6 months. We didn't expect the effect to last so long, so we didn't actually continue following the patients, but you can see there that the OSDI was continuously going down. Similarly, patient severity, symptom severity and frequency also decreased over the period of the study. But one of the really interesting things for us is that we were monitoring nerve health parameters using IVCM, which is in vivo confocal. And we were able to show, the study was able to show a significant improvement across multiple nerve parameters. So this is quite exciting for us, because if we can actually dial back the damage that dry eye has done to the ocular surface, it gives patients hope. And what we were able to show was that 74% of participants in this study had at least a 30% improvement in their nerve quality at 1 month. And this is something we're going to continue researching. In a similar vein, the IVCM allowed us to count and look at corneal dendritic cells, which are inflammatory cells in the cornea, and they change shape depending on whether they're activated or immature. And what we were able to show was that there was a significant and 30% reduction in the activation of these inflammatory cells as a result of the treatment. And we were able to corroborate that with the accumulation of immature. So rather than them being destroyed, what we think that the amnion is doing is blocking their activation. So it's a immunomodulatory role. Again, this was a novel discovery for us, and we're looking into it further. So in summary, the advancements that have been made in sutureless amniotic membrane is giving new options for the management of ocular surface disease. And it is a simple and cost-effective procedure. It's non-invasive, and it is very easy to access. The treatments with essentially one application can give rapid and sustained benefits, and this is even in hard-to-heal conditions, so it's quite exciting. It's a versatile treatment option, so you can start to consider various different ocular surface diseases, and some of them more superficial, which haven't considered in a previous time. And we've shown that the treatment strategy is easy to do and it's safe. By removing iatrogenic damage from the surgery itself, you are actually adding an extra dimension that can improve clinical outcomes. And again, just to put it in the context of why we're here, the treatment is a promising option in the armory of management of AAK. So it's something that I'm really excited to engage with you all and discuss further. And my commercial team have just asked me to put this in, that we've now been approved in Sweden, and we are working with Medilens to actually make this available in Sweden. Acknowledgements, so I'd like to thank the research team and all the clinical team at the University of Nottingham, and then the clinical teams that have done the clinical work at Aston, QVH and Bristol Eye Hospital. And then the funding that's enabled some of this research is from Innovate UK, and then regional NHS-driven funding streams. Thank you very much for your attention, and open to questions.
Thank you. Very interesting. So I'm sure you have looked into the mechanism of action, I suppose, of this. So what is it? Is it the storage of pro-inflammatory cytokines or extracellular matrix proteins in the membrane, or how do you think it's working?
I think the simple answer to that is yes to all of those. I think the reality of the situation is amnions are very complex biological tissue that has both trophic, soluble, and structural mechanisms of action. And we are now endeavouring to try and understand some of that mechanism. But if you knock one out, it just gets compensated by another. What we do know is if you don't preserve the tissue right and you affect the blanket soluble competence, so all the biological factors, that does decrease the function of the tissue, but it still works. So there is definitely the structural element that still has a benefit. How we can tease these out, and it's a question that I get asked all the time, and I've been in this area for 20 years, and I'm no closer to understanding.
Yeah, I'm kind of surprised that you can put this to patients' eyes, I suppose, without knowing really what the effect is of this. You know, we're working with stem cells and vesicles, so they are asking us what is the mechanism of action. Otherwise, you cannot go into to the patient. So
I think the answer to that comes down to how it is regulated, because we're not manipulating it and it's classed as a human tissue transplant. We cannot indicate, we cannot market it for specific indications. All we can do is provide the evidence that is available in the public domain, and it comes down to homologous use. So we are allowed to say that it's immunomodulatory because that is one of the functions that it provides in vivo around the baby, protecting it from the mother's immune response. So that we can get past that because it's human tissue, and this is why my view is that keeping some of the therapies as simple as possible and utilising what we already have can greatly reduce the development pathway and cost that can get you, even if it's a short-term or intermediate-term treatment, while some of these promising long-term strategies are being developed.
Thank you.
Thank you. Interesting product. Just a short comment. In Sweden, the amniotic membrane is easily available and has been for many years now, and it's actually even cheap. And the results basically depend very much on the etiology, as you mentioned. And yes, of course, it works in many cases very good, and in the others not at all.
And I can continue. I took the mic directly from Branka. I have the same experience as she, as being a corneal surgeon, but I'm also concerned because I'm medically responsible for our tissue bank in my home hospital. And what about the traceability? I mean, I guess you have the donor in UK, And I'm not ready yet. And if you have this available at your stands, and if someone takes that from your stand, how will you be sure that this is a tissue? It's under the tissue regulations from EU. It will be even harder in 2.5 years. It is mandatory to have the traceability, whether if your patient turns out to have hepatitis or HIV or Creutzfeldt-Jakob. I hope not. But this is a tissue, so it's not like any contact lens.
Yeah, I mean, I agree with everything you're saying. We're under no illusion that we have to follow regulation. We are heavily regulated in the UK by the Human Tissue Authority. It's been through the review and assessment of the Swedish competent authority, and we have to follow all of the necessary tissue traceability. So NuVision is a tissue bank, a tissue establishment in the UK. We have the full traceability of all consumables and donor which go into the product. The product has an SEC code. So when we then transfer it to the tissue bank that's been authorised for importing the tissue in Sweden, they assume the traceability from the point of entry to the donor, and therefore they will have all the records of where it goes. So every unit that goes out has stickers that will be put into the patient records, and then the clinician then reports back to the tissue bank who they've used it in, how and when. So the traceability is an important aspect, and it's a priority to us, and we've managed to put the processes in place. I mean, we now supply 10 countries, and traceability is maintained throughout all of that. And we are aligning our testing strategies and our donor criteria to any other country that we.
I understand, but. Does every general practitioner that will use your contact lens with this know about this traceability that you really have to apply with for the recipient? And then I wonder, you said that there is a tissue bank in Sweden that will deliver these. Which eye bank is that, or what sort of tissue bank is that, and why?
So it's a tissue bank based in Stockholm. And
she's sitting beside me, and they don't have it.
Cella Viva.
The tissue, okay. And what do they do?
Is it a commercial actor? Or?
So they are a fully registered tissue bank that's been approved by the Swedish competent authority to be able to. They already had a tissue bank license for amniotic membrane and for import of tissues, and we've just plugged into that existing process.
Thank you.
Okay, thank you.
Yes, thank you very much for a fabulous talk. My PhD was related to amniotic membranes. I remember I prepared those membranes 15 years ago. Thus, I'm fully aware of the previous challenges with those membranes limiting its use. It's very rare I'm this impressed with a talk, and last but not least, the technology behind all these improvements. I strongly believe in your product. I see enormous potential for numerous diseases and also dry eye disease, moderate to severe cases. So my sincere congratulations.
Thank you very much.
I think there was another question. Yeah, over there.
We have a number of people in the U.S. that I imagine could benefit from something like this. I'm wondering if you're working to bring it to there and what the challenges might be there.
Yes, the US is definitely on our 3 to 5 year strategy. We're currently setting up the markets across Europe. The challenges are the same in every country. It's regulations, making sure that we fulfill all the necessary local requirements, and we have a dedicated team to make sure we do that. And we understand what we do before we go and do it, and we don't cut any corners. So with the US, yes, there's a lot of established amnion producers out there. So it sets precedent, and there are predicates for us to follow. But it's just implementing that and then having the necessary resource and infrastructure on the US side for us to be able to pick that up and take it forward.
Okay, thanks. Just one question, because otherwise we go out of. Can I go back to what Barry was saying? Technically, to have your contact lenses, amniotic membrane contact lenses, a patient cannot come over to your They always need to go to their doctors, and their doctors goes to an eye or a tissue bank, and then the tissue bank gives the tissue to the doctor because of the traceability.
Yeah, it's exactly the same process as what it always has been, either through an ophthalmologist or because this now, in the UK, this is now being approved by the AOP, which is the Association of Optometrists, to prescribe. But for them to be able to do that, they have to go through a certified training program, which is understanding patient selection, the actual application, the risks and benefits, and also the regulatory requirements.
I mean, so nobody can come over to your booth and take an amniotic.
Oh, no, absolutely
okay.
not. The units that we have are demo units that they've been logged in our traceability. Okay. We have a clinical waste bag that once we've actually used them for demonstration that they get disposed of, and we keep hold of them.
Okay, it was just to make sure that we are not, giving away products made of human tissues here at the conference.
Yeah.
Okay, thank you. Yeah, in iBank, I was very worried about that.
Yeah.
Yeah, exactly.
No.
Okay.
The units are actually marked as demo.
So there are no tissues here, apart from demo tissues.
It's pure demo,
Purely demo
that
tissues.
we will be disposing of.
Okay.
Can the clinic buy some, or do we need one clinic? If one clinic is interested in buying these contact lenses, can we buy some and use them during a period of time, or we need to apply for each patient?
So
is it directly available in some way?
So we go through the regulatory process in each country through the competent authority. Once that's been approved, it is available either through tissue banks, or we've got commercial entities working with tissue banks, and the commercial entities do all of the engagement but don't handle the product. All of our logistics will be going through tissue establishments. So once it's approved in the country that you are, if you're in Sweden, you can access it through the proper channels and following the appropriate training.
No, I don't understand yet. So if I'm a clinician and I want to use that for a patient, do I need to go through the tissue bank every time?
Yes.
So I cannot buy for the clinic like to have 10 in place, like a normal contact lens. I use them when I need it.
So the contact lenses you can buy and store on your shelf like a normal contact lens. The amnion has to come through whichever tissue establishment or mechanism we set up. Each country has its own version.
So it differs depending on the country.
Yeah.
And do you know how long they take for them to degrade? So when I use it in the eye, when do I expect that this amniotic membrane disappears?
So the longevity of the tissue greatly depends on the inflammatory status of the patient. So
it varies.
In the more severe, like SJS patients, the amnion degrades in around 7 to 10 days. But in PEDs, we get reports back from clinicians that they've taken the lens out and it's in the lens still.
Okay, thanks.
Yeah. I think we need to move to the next speaker. Thank you very much.
Thank you very much, everybody. Thank you.